Welcome to this ADCES 20 session T05, advocating for the 4 critical times for diabetes self-management education and support with primary care providers. I'm Hope Warshaw, a dietitian, certified diabetes educator, and proud past president of ADCES. I own and operate Hope Warshaw Associates, a consultancy in diabetes and nutrition based in Asheville, North Carolina. I'll be your moderator for this session. Our speakers, who I'll introduce in a moment, will be sharing details from the recently published 2020 DSMES Consensus Report for Adults with Type 2 Diabetes, revising the 2015 publication and orchestrating this with 4 new organizations you'll hear about was a monumental task. This is a critical document for you to be aware of as ADCES and diabetes care and education specialists pivot and expand our roles in the care of people with diabetes and in healthcare systems. Beyond the consensus report, our speakers will share the resources that have been developed and are readily available to help you magnify the content and import of this consensus report. It is my privilege to introduce this session's speakers, who are both longtime colleagues and friends. Very briefly, Maggie Powers is a research scientist at Health Partners in Minneapolis. She was co-chair of this 2020 consensus report. Maggie served as president, healthcare and education for the American Diabetes Association in 2016. Joan Bardsley is an advanced practice nurse and vice president of nursing and research integration at MedStar Health Research Institute in Washington, D.C. Joan served as president of ADCES in 2014 and was also co-chair of this 2020 consensus report. Learn more about each speaker in the ADCES 20 app. During the program, feel free to put your questions in the chat box on your screen. Be aware that Q&A time is limited and speakers will respond to as many questions as possible. The following are the disclosures, and neither Maggie or Joan report conflict for this presentation. I will now, as the slide is turning, turn it over to Maggie.
Thanks, Hope, and I'm delighted to be presenting today along with my co-chair of the 2020 DSMES Consensus Report. We're delighted to do this for you, diabetes educators. We know that's the primary audience for this presentation, and we have tailored it for you. And we want to highlight that our goal is to introduce you to this 2020 consensus report and to identify resource material. So you may have read it already, but it's hot off the press. It was just published online in June and is now starting to come out in the print publications of the various journals of the participating organizations. So you can see our objectives here in addition to our primary goal. We are going to talk about the details of the consensus report, but we have a bigger picture for you as diabetes educators for this presentation. So let's kick it off right away with saying what's different about the 2020 consensus report. Why did we update it? You know, it takes a lot of effort, a lot of coordination, a lot of time, and so we looked at the 2015 and evaluated what we should do. And we definitely said it's time to update it. And here's a summary of the changes that we made. We expanded the collaborating organizations. The first time around we had 3, which we were delighted to have, and this one we added 4 more, and I'm going to show you the list of collaborating organizations in just a little bit. The target audience is now for primary care providers. We know that you as educators get diabetes education, you know the value, but we need to be sure that patients are getting to us, and it's primary care providers are key in that respect. So you'll see a different tone in some of the paper because that is the audience. The benefits, we always have the benefits in the first paper, but they are highlighted, and I'm going to show you 2 different tables that we included in this paper to highlight the benefits. We updated the graphic for the 4 critical times. The first time around, we were excited about presenting the 4 critical times and had a graphic, but this time we actually had an artist involved, and we are excited to be showing you. If you haven't seen it yet, I think you'll be quite pleased with it, and we hope that you use it. Barriers, we talked about barriers in the first paper, but we expanded the perspective of barriers, and we actually summarized them into 4 different topic areas, and Joan will review those barriers later when she speaks. Recommendations, this is a key part of this paper, is that we have specific recommendations, and we're going to detail those, summarize the presentation with those toward the end, and those are a big takeaway. So we really think that these are what we need to do to move ahead and advance the goals of the consensus report. We have an emphasis on healthcare team, access and referral, population health, solutions to barriers. We took a lot of time to say this is how you can address different barriers. We don't have all the answers. They're always, individualized to your particular setting. But when Joan goes over the barriers, I think you'll understand how we advanced, how we presented them. And we have reimbursement options. So also what's key to you as our audience is that we've expanded resources to support your implementation and dissemination. We had some resources for the first one. We don't know if everybody knew about it, but we do in this report, and we actually have a web page set up just for our resources, and we're delighted that ADCES has provided this web page, and this is the URL, so it's diabeteseducator.org/consensus report, and that will get you to a variety of resources. And here I've summarized what we have there. And this is the key part of what we want to present today, is that you are a part of getting the word out about the report. It can sit in the journals, it can sit on the internet, but we have to share this. And part of what we're sharing are our slides today. So it's a presentation about the report, but it's also showing you what the slides are and how you might use them in presenting. So let's first look at the left-hand side of this particular slide, and that is if you want to know where to get the consensus report, you don't want to muck around looking for it in a different journal, you don't remember how to access a journal, it's right there. You just go to diabeteseducator.org consensus report, and there is a PDF of the consensus report. Also, there's the 2 supplementary tables. There is a table with additional resources and a table of codes. And this is really important, is that it's either 5 or 6 pages, tight pages long, and we were going to include it in the report, but it required so much space that we made it a supplementary table. So not to say that it's not valuable, but we just didn't take up part of the consensus report for it. But there is a long list of codes that you can use for reimbursement purposes within your health facility that relate to diabetes education and self-management support. Very valuable. Over on the right side, you see that we have a customizable PowerPoint presentation, and many of the slides that you're going to see today are in that presentation. Now, when you take a presentation, you modify it for yourself. You may just use one slide. You may use one slide as a presentation, so you're doing a Zoom presentation to or a meeting or to colleagues or to a broader group of people. You can use one slide, you can use all 27 slides. You might pick a slide. You'll see that we have a slide with our graphic. So you might have that just on your desktop ready to pull up when you're talking about education where you work, or however you work. If you deal directly with people with diabetes, or you're working in a management area, or you're consulting, you might want to have that graphic readily available, or some of the other slides. There's a podcast, 20-minute podcast. There's an article about how DSME consensus report can shape diabetes care in the post-pandemic world, which is awesome. There's a video directly for patients. So maybe this is something that you want to share with your patient population. Maybe via telehealth, you have the capability of sharing a video, or you have the capability of sending materials, and there's a flyer appropriate for sending to people with diabetes. And just so you know that on that flyer, it lists the 4 critical times, so they're talking points that you can talk about, and there's also a list of the 7 self-care behaviors that you can talk through. And there's more to come, and so I'm going to move on to the slides, but I want to highlight that we also want you to tell us what else you need to facilitate your use of the consensus report. Highlighting the value of this consensus report is that there were 7 organizations. So when you do talk about it, you're talking with the voice that this paper was endorsed by these 7 organizations, and you can see them listed here. This time around, we added the family physicians, the PAs, the nurse practitioners, and the pharmacists. And so they were all at the table with us working this out. And the final paper went through all the endorsing processes of those 7 organizations. So it was reviewed at the top levels of all those organizations. So when you talk, you are reporting out based on the strength of these organizations. These are the authors that Joan and I were privileged to work with, who brought their expertise and shared their valuable time to make this paper just right for 2020. And we thank all of them. So when we got together, we said, this is the situation. We have the diabetes epidemic. Diabetes is expensive. Target goals are not being met, and it's not being utilized per standards of care. So there's a call to action in the paper that we need to communicate the benefits of DSMES, engage stakeholders, address the barriers, and make patient-centered or person-centered diabetes care a priority. So how does DSME support this call to action? Well, we know DSME improves health outcomes, quality of life, and is cost-effective. Yet it's underutilized, and this can change. And that's what this paper is about. We want to change the utilization of diabetes education services. We know that only 5% of Medicare beneficiaries with newly diagnosed diabetes cares use the DSMT services benefit. You're newly diagnosed. You have a short, brief time with your provider. You have so many questions. That's what we do. We help with those questions. We help people start their journey with diabetes on the right foot. And we have the time, we have the focus, we have the expertise to do that. So we certainly want to see people when they're diagnosed, and also at all 4 critical times. We know that DSME should be flexible and person-centered. And on the left, Joan and I wanted to include this because we know that we should individualize glycemic targets based on a variety of factors like diabetes duration, life expectancy, the comorbidities, what's the patient's preference. Well, the same thing with DSMES. We want to provide the right intervention at the right time, in the right place, using the right workforce. Here's one of our tables about the benefits. So when we talk about increasing utilization, this is the basis of why we need to increase utilization. This is a long list of the benefits that are discussed and referenced in the paper. The paper is highly referenced. It gives you more detail if you want more detail about any of these benefits. But you can see it provides critical education support for implementing treatment plans, promotes lifestyle behaviors, including healthful meal planning, engagement in regular physical activity, addresses weight management, increases healthy coping, decreases diabetes related to stress, improves quality of life. And you think of what everybody's going through right now with the pandemic, certainly we can help people with many of these aspects. We also have another table in the consensus report about the benefits, and it's answering the question, if DSME were a pill, would you prescribe it? We know that many pharmaceuticals are prescribed for the management of diabetes. We also feel that DSME can be just one another prescription that can be filled out that's part of diabetes care. So when people are diagnosed with diabetes, there's typically a prescription written for metformin, and then it has to be reviewed and updated, rewritten. Same thing with DSMES. It needs a prescription. We need a referral. So we can just look at it like a prescription, but you write the prescription and every year it needs to be renewed. So here's the comparison though with metformin, and another reason why we feel so strongly that we need to increase our utilization. Medications are evaluated based on efficacy, the risk of hypoglycemia, weight, side effects, cost, and psychosocial benefits. The psychosocial benefit is something that we added, but you can see compared to metformin, the efficacy of DSMES and MNT was included in this research, in this evaluation. It's high, metformin is high. The risk of hypoglycemia is low with DSMES, it's low with metformin. Weight is neutral or loss with DSMES, it's neutral or loss with metformin. So you can see our services compare greatly with a common medication that's prescribed when people are diagnosed. What is unique to us is the long list of psychosocial benefits that we offer with DSMES and MNT. And they're down at the bottom of the slide. And again, they're highly referenced, and you can look at the references in the actual consensus report. But again, we improve quality of life, self-efficacy, empowerment, healthy coping, knowledge, self-care behaviors. All of that is what people with diabetes need to do daily with their self-management. So we feel that the benefits are there. We need to shout them louder and stronger, and to be sure that we get the referrals, that patients are referred to us at these 4 critical times. And so this is the new graphic. If you're seeing it for the first time, hopefully you like it, and you can see that the 4 times are in the 4 boxes: at diagnosis, annually, or when not meeting treatment targets, when complicating factors develop, and when transitions in life and care occur. Now, actually, the paper goes into much more detail about what factors at each of these 4 critical times will initiate diabetes education. Joan's going to review those in a little bit more detail in just a bit. But you can see that these aren't necessarily sequential. You can see that there's little arrows going from time to time. It doesn't mean, and you do start at diagnosis, we want to start there, but it could be that you have a complicating factor, and so you need to go there next, and then maybe it's an annual visit. So it's all of these times whenever they happen in the life of somebody living with diabetes. So before I turn it over to Joan, I want to show one more slide, and that highlights the center of our graphic, which is the 7 self-care behaviors. And we know that we don't cover them all at every visit, but they're the essence of what we do. So when we show the graphic and we talk about the 4 critical times, we can also talk about what it is that we do. So with that, I think my next slide turns it over to Joan.
Thanks, Maggie. Really appreciate that background information. And just to emphasize again how excited we are to be here, and to thank all the people who contributed to this consensus report. It was just amazing that we were able to get such prestigious organizations all to recognize the importance of diabetes self-management education. Oh. Thanks. All right, you saw the big graphic that we had, but it was important, as Maggie indicated, that these are slides that are available to everybody on the website. And so this is the slide that you can use when you're talking about at diagnosis. One of the really important factors that we learned from our colleagues who are providers is what happens when you go to diabetes education. It's like a black box sometimes. I'll refer, but then I'm not sure what is being taught or what the focus is. So what we did was we took each one of the 4 critical times and kind of broke it out a little bit more. So someone is newly diagnosed, they should see diabetes education, but we also make sure that they have both nutrition and emotional health that are addressed at that specific time. We have in the paper a checklist of not being prescriptive, but to give an idea of what should be covered during the time of diagnosis. And so that could help guide what we are covering as educators, but also what providers can also be doing during that particular time. So if you were giving a lecture or something, you could use this slide to get into more depth as to what happens during the time of diagnosis. Same thing when it's annually or when the person is not meeting treatment targets. And so to give more guidance, when knowledge and skills need to be assessed, we think it's important providers need to know that so they can refer. Someone might have limited or long-standing diabetes but didn't have education. We've all been in those situations where someone will say to us, why didn't we know this before? The treatment's ineffective, if there's a change in medication activity or nutrition intake, etc. So you can go through these specifics, but the idea is we wanted to give some background when we developed the paper and when we developed these toolkits to give some indication so people have a better idea of what we're doing when we're providing diabetes self-management education services. The third time that we talked about is when complicating factors occur. If there is a change in health condition or health status, physical limitations, emotional well-being, basic living needs, that's something we can help with, and we're really, really good at it. So it's a great time to refer during this particular time. So again, we want to give guidance on what happens when someone is referred to us for diabetes self-management education and support. The fourth time is when transitions in life and care occur. This was a little trickier because it's really across the continuum. We are transitioning all the time. We live across the continuum. So if there's a change in living situation, it happens often. Discharge from inpatient to outpatient. If there's a new clinical care team, it's great to see education or to see diabetes educators in order to figure out what are new plans, what are the important things I need to discuss. If there's an intensification or initiation of therapy, devices, or technology, and that is certainly these days happening a lot more than it did in the past. Who's teaching? Who's spending the time, not just to do the technical skills, but the interpretation skills? And clearly that's something we do. If there's insurance cover changes, age-related changes, these are all great times to transitions that an educator can be so helpful in helping the person navigate these particular times. As Maggie indicated, these do not or should not be used sequentially. Clearly at diagnosis is a set point in time, but the other pieces are dynamic, is when things change. That's an important time to refer back to educators. So we're hoping you use these particular 4 slides to help educate people on when education is important and when a referral should be made. So that's why we broke them out into individual slides in addition to having the big graphic that is kind of our centerpiece for this paper. There is also a checklist. I had mentioned that before, and we kind of went back and forth. On the right-hand side is what it looks like in the paper. And I was bound and determined not to have a slide that said, I know you can't read this, but just to give you an idea, that is in the paper, and it really goes through very specific areas that could be covered during a particular time. So we wanted to make sure that that you realize that this was available. And of course, these are all tied back in some of the cases to the 7 self-care behaviors that that we are all so familiar with. So it's available in the consensus report. It provides content guidance for each critical time, but again, not prescriptive. It gives guidance. And it differentiates the content between a provider's team and the education team. If you recall from the first paper, they were color-coded. This is a little bit different, but it still does provide that guidance, because the providers often say, well, I go over this. Well, what is gone over by the providers could be very different than what is gone over and reviewed and taught by the education team or supported by the education team. So this helps differentiate a little bit more and gives that guidance, again, to both the education team as well as the provider. So we hope you use this very frequently and share this with your colleagues. As Maggie indicated up front at the beginning, we always hear about barriers. Why don't people utilize diabetes self-care and education services? So we tried to address that in the paper. And we broke it down into 4 areas: health system or programmatic barriers, referring healthcare providers barriers, participant-related barriers, and environment-related barriers. From a health system perspective, they have specific needs. They want to know, how much is this going to cost? How much is it that I have to invest in order to have a great program? Very realistic barriers from a health system. So we tried to help navigate that and give some solutions and some talking points that we can have with our administrators. With the healthcare providers, they're always asking, and they ask this many times, how do I find an educator? What happens when a person goes there? Do I hear back? Who's adjusting medication? So we try to give bullet points, again, that are specific to the healthcare providers. Participants in diabetes self-management education and support also have specific barriers. What time are the classes? How much is it going to cost me? What if I don't connect with the educator? Are they just going to tell me not to eat sugar? So we try to, again, address some of the barriers that the participants may have, and also looking at the environment. And we are certainly in a different environment now than we were 3 months, 6 months ago, and a year ago. So what's the environment in which we are delivering our services? And so we talk about technology, we talk about utilization of technology, and we try to give some pointers in order to make it a little bit easier to address the barriers that really are in front of us each and every day. So the bottom line is we're trying to provide the right intervention at the right time, in the right place, and using the right workforce. And I think that's very familiar to you, is that's really a population health framework that we tried to reinforce during this paper. So one of the key pieces that we came out with in this paper were recommendations. We were taught, once again, just tell us what to do. What do you recommend we do? Just tell us what to do and we'll do it. And those were the providers saying that to us. So we really wanted to come up with very specific recommendations that were for the different audiences that hopefully will be reading this paper and utilizing it to frame their education programs. And so we'll go through these a little bit in detail now. Okay, so the first one is the report recommendations for providers. And there were 4 that we came up with. And so these are what we hope providers will say, that we will say to providers, here's what we need you to do. We would like you to discuss with all persons with diabetes the benefits and values of initial and ongoing diabetes self-management education support. We need you to initiate referral to and facilitate participation in these services at the 4 critical times. And so these words were very deliberate. So we know they have to refer, but we also want them to facilitate participation. If a person does not go, what happened? Help them to make it easier for them to participate at these 4 critical times. We're also recommending to the providers that they ensure coordination of MNT with the overall management strategy, including the DSMES plan, medication, and physical activities, and this on an ongoing basis. Clearly, we don't do each one of these activities in silo, so we're recommending to the providers that things are incorporated, that they're coordinated. And then the fourth recommendation is for the providers is to identify and address barriers affecting participation with the services following the referral. Don't just refer, find out what happened. Were there barriers? How do they address them? And we can help the providers in that activity. The next three recommendations, so we have a total of 7, actually are recommendations for health policy, payers, systems, providers, and the care team. What we recommend to these groups is to expand awareness, access, and utilization of innovative and non-traditional services. We are asking them to market. We are asking them to include these in their plans. We are asking that technology is used. How do we utilize and support the use of technology and make it easier for the diabetes education services to be utilized by participants? We also recommend that they identify and address barriers influencing the provider's referrals to these services. Where's the accountability? Where are the dashboards that are there? Where are we really measuring how many of the participants, how many of their patients are referred to diabetes self-management education services? So really looking at what are the barriers? Why not? What are the issues influencing you referring for these services? And then the final recommendation for the policy payers, systems, et cetera, is to facilitate reimbursement and processes and other means of financial support. Often we hear that, well, we can't afford to have an educator. We'd like to propose that they can't afford not to, because if you're truly looking at value-based care, if you were looking at what education services do to improve both metabolic as well as psychosocial and behavioral issues, then it's so critical that everyone understands these values. And what kind of processes do they have in place to make sure we are fully capturing any of the reimbursements we can have, and also looking at the influence it has on the system as far as reduced emergency room visits, repeat admissions into hospitalizations, et cetera. So these are the recommendations that we have for this particular group. So 7 in total, and we broke it down to make it a little bit easier and to make it more directed as you are out and working with all of these groups, that you can tailor your presentations and tailor what they need, tailor what you're giving them to what they actually need. Okay. So again, we really thought this was important that you understood, that you know where to look for this information, and it's diabeteseducator.org/consensus report. There are many tools there that are listed on the right. We hope that you use the slides. You've seen many of them in this presentation, so please download them, use them. Feedback is always, always welcome, so you can get in touch with ADCES. You can email Maggie or myself, give us a call, and we would love to chat with you and know how that you're using them or any changes that need to take place. Okay. So in summary, and we thought this was a great slide that you can use in your presentations when you're talking about education, is there are many evidence-based benefits of DSMES, including psychosocial and behavioral improvements. We also know that it's underutilized. We know that the consensus report describes the 4 critical times to provide and modify this, what we provide to the patient or the person with diabetes based on what their needs are, provide clear guidance as to when to refer, includes a checklist for providers in diabetes care and education specialists who are providing and modifying the services, and that health systems and providers should mobilize to ensure all people with type 2 diabetes have easy access to DSMES, nutrition, physical, and emotional health support, and consider automatic referrals for all of these services. I know we are looking at how do we automatically get a referral made if someone is newly diagnosed. as opposed to having to do a physical thing. Can a referral just pop up and it's more of an opt-in and rather than opt-out service? So those are some of the summaries that we have in the paper that we thought this might be important for you to have as you are out talking to people about what you provide. And we just wanted to end with this very short concept of what we feel about education. First is from Dr. Albert Schweitzer, is every patient carries his own doctor inside him. They come to us knowing the truth. We are at our very best when we give the doctor who resides in each patient a chance to work. And I think we need to do that. And I think as educators, we actually do that very well when we empower someone to take care of their diabetes. Nelson Mandela has quoted that education is the most powerful weapon which you can use to change the world. And I think we can expand that to say diabetes self-management education support is the most powerful weapon we have to manage diabetes. We have the ADA standards of care that all people with diabetes should participate in diabetes self-management education and receive the support needed. And then from the 4 critical times consensus report, we know that there are critical times that are based really in evidence to provide and modify diabetes self-management education support. So those are some quotes that we just thought really tied in together what we feel about the consensus report. And so at that point, I'm going to say thank you so much for attending the session. We hope this is helpful to you and gives you the tools that you use to help expand the number of referrals that the person with diabetes truly deserves in order to manage their diabetes independently. So please put any and all of your questions in the chat box, and Maggie and I will happily answer them.